one from, actually both from here locally in town, which is going to really round our group out. So I'm glad HET was a sponsor of the Perf Web series and the Tammy Sparacino Journal Club, because it helped us, I think, get those positions filled. So we're really excited about that. On social media, and check us out too on het.us. On social media, make sure you like, follow, share, subscribe, give us the thumbs up, click the bell icon, all that stuff on Facebook, Twitter, LinkedIn, and YouTube. Those are really important. The subscribing is critically important. It really helps us a lot. And give us the thumbs up. We really appreciate that as well. Our websites are perfusioneducation.com and perfweb.us. Perfweb.us is our schedule. Perfusioneducation.com is a free membership site, so membership is free. You can watch and participate in all of our programs, but if you want to become a paid subscriber, then you can either pay as you go, or you can get an unlimited subscription, and you can use that to keep track of all of your CEUs, get everything you need for the year. I know meetings are opening up. I'm giving serious consideration. In fact, I said I was going to do it in June of 2022, do the New Orleans conference again. I'm still seriously considering it. And I will let you, of course, you'll know when I do it, because I'll send out a flyer like I normally do, and you'll know that the New Orleans conference is going to be back. Is it going to be bigger? Is it going to be smaller? Is it going to be the same size? I don't really know. I haven't figured out all the logistics yet, but we really want to do it because I think it was such a great conference. I think it was known as really the best conference ever, and I think it was too. Contact us at perfusioneducation.com if you want to ask a question, you want to add a topic, you want to participate and be a faculty member. I could sure use some help. Tammy's working, Mike is working, Min is working, Patrick's working, Nate's working, everybody's working. In fact, when I finish this program, I have to go back to work as well. So we're still really busy. I don't know what's going on, but it's just still really busy. We still have an ECMO. I'll talk more about that here in a second. Our call-in number. We're going to open the phone lines early. If you want to call in, please do. You can be live on the air. If I'm in the middle of the lecture, please, and my slides, it doesn't matter to me. Just call in if you want to be part of the discussion or you have a comment or a question. Doesn't bother me at all, but we also have YouTube chat, Facebook Messenger, and whatever Twitter has. I don't know. Whatever the social media is, you could use whichever platform. We have Magic monitoring it right now. He leaves every once in a while to go find a nurse, but then he runs right back. And so, because we are looking for a nurse as well. You know, I may as well put this out there. We are looking to hire a nurse to work in a multifunctional role. One of those is for nursing education. So if you have an interest in that, and also doing some administrative work, but participating in these programs from a nursing perspective, and also doing some autotransfusion work. I think we are going to transition eventually to nurse ECMO specialists. So if you have an interest in things like that and think you might be able to help us in the educational realm, that's one of your passions, reach out to us or pass this on to your colleagues or friends that you may know that have that interest. Our MediWeb app, you can locate it on Google Play or you can locate it in the Apple Store. There are two apps. One is an IV drug dosage rate calculator, which is also incorporated in the critical care and perfusion app, which you'll see there. Check those two apps out. It's under MediWeb. One is 99 cents, the other one's $2.99, and the 99-cent one is actually part of the larger $2.99 app. But it's got a lot of functionality. In fact, I'm going to use it during one of my presentations today. But check it out. I think you would. It's a really great tool for perfusionists, critical care physicians, ECMO specialists, nurses, whatever. I think it really has a lot of value. And we worked very hard at putting it together. We're getting ready to launch an update, which I think we need to do sooner rather than later, but we've been working on the update to make sure that it's a good update and it adds even more value to the tool. Podcasts, you find us on whatever your favorite streaming platform is. Look for PerfWeb Podcast Series, and you will be able to find us and listen to us while you're in the car, driving to work, stuck in traffic, on the beach. And if you're doing that, you've got real issues. But you can do that if you so desire, okay? I want to jump, if we can, right into something, because one of my lectures today, I'm doing 2 lectures. One of them is actually going to be one of Tammy Sparacino Journal Club's programs, and the other one is going to be on predicting survival for VA ECMO using the SAVE score. And I think they're both really good programs. But so let's just jump right to, I'm going to go to the wheel first. And I want to talk real quickly about a guy. His name is Alan Klima. That's A-L-A-N K-L-I-M-A, and he's with Perfusion Designs. Now, Alan was kind enough to send us at no charge, so he donated all of this stuff. Some really cool stuff. There's surgical caps that you can see here that you can wear that have a neat little saying on it that you can wear in the operating room. Let's see if I can get it straight. There it is. Okay, yep. So you don't want to look goofy, so you want to make sure that it's straight. Okay, we have these. We have some really cool ball caps. They come in a variety of different colors, even camo. And we have these really cool T-shirts. And the slogan on the T-shirt says, "Perfusion, we give your heart a rest," and cardiac surgery. They come in a variety of colors. And I wanted to thank Alan for this. It was very kind of him. I actually found out about Alan through John Ingram. He's good friends with him. He has an email. You can't put this up, can you? Actually, okay, we'll add it in the YouTube description, and it's ALW Klima, @gmail.com. He has an online store, but it says the website's not completed yet. He can take orders for these things. He can custom make some stuff for you. But like I said, really cool stuff. And then we have the PerfWeb cups that you've seen before. They're great for your hot cocoa or whatever it may be while you're waiting for your transplant in the middle of the night. So we're going to spin the wheel. Now, I'm going to see if we can do this because you can win Extra Call, everybody's favorite, a ball cap, $10 Amazon, T-shirt, cup. You can win an aortic dissection case. Those are always great, cup, ball cap, and so forth. So I'm going to go ahead and spin the wheel, and whatever this is, the first caller or the first good question, and it has to be a good question relevant to the program topics, okay, that we get on any of the platforms that you're watching from, you will win whatever it is I'm going to spin, okay? So we're ready? So you're going to win Extra Call. No, I'm just kidding. Okay, so we're really going to spin it for real now. Okay, there we go. Whatever it is what you're going to win. God, I hope it doesn't land on that aortic dissection. Oh, come on, come on, come on. All right, good. So you're going to win a ball cap. It won't be this one in particular, but this has never been opened, so it's not been on my head. I wouldn't send you this surgical cap. But it's a ball cap. You can ask for the color. It could be in camo, green, this color. I think there's black and red. So you could just ask me which one you might want, and I think dual color as well, and we'll do that. So whoever does good question on one of the platforms or calls in wins the ball cup. All right, so let's go ahead and get right started with the lecture if we could. And so this is one of the talks that Tammy was going to give, and actually I was going to give it during one of the other programs, but our schedule has just been so incredibly crazy with everything that's going on. We still have COVID ECMO left, but it's been slowing down for us some. I don't know what other people out there are seeing. Certainly the society has opened up tremendously. I go into places now and I don't see anybody wearing a mask or anything like that. Most restaurants I go to, other businesses, some businesses are still asking for people to do that. I've gotten so used to it, even though I hate it, that I still wear it in the grocery store. But we do have, a few patients left. But we have also just been incredibly busy with hearts, and it's sort of like it's been a, I don't know if it's just a swing of the pendulum from these patients who were on the waiting list, essentially not coming in because of COVID, but we've just had a massive rush of cases. And some of them have been a little more complicated than a lot of the other ones that we're used to seeing. Haven't seen as many chip shots. We've had some very complex, difficult cases to do, and I think these are patients that just got held off for a long time. But no, you can go ahead to the slides. I'm sorry. I mean to do that. So I'm your guest host, Joe Basha. This is a Tammy Sparacino Journal Club presentation, and the topic is lower or higher oxygen targets for acute hypoxemic respiratory failure. So when we see patients that come into the operating room, or the ICU, whether it be for COVID or whether it be influenza, whether it be aspiration pneumonia, whatever the situation may be, they have an acute hypoxic respiratory failure. And how do we treat them? Do we treat them with lower or higher oxygen targets? So the methods of this talk, by the way, which was published in the New England Journal of Medicine, January of 2021, and updated on April 8th of 2021. So in this multi-center trial, the authors randomly assigned 2,928 adult patients who had recently been admitted to the ICU with equal or greater to 12 hours before randomization, and who were, I'm sorry, less than or equal to, forgive me, and who were receiving at least 10 liters of oxygen, so that would be sort of a high flow oxygen in an open system, or had an FiO2 inspired oxygen content of at least 50%. So they were set at 50% in a closed system, that being on a ventilator. I guess that would also qualify BiPAP as being part of that. And to receive oxygen therapy targeting a PaO2 of either 60 millimeters of mercury, which was considered the lower oxygenation group, or 90 millimeters of mercury in the higher oxygenation group, for a maximum of 90 days. The primary outcome was death within that 90-day period. So patients with acute hypoxemic respiratory failure in the intensive care unit are treated with supplemental oxygen, but the benefits and harms of different oxygenation targets are unclear. We hypothesize, this is the author speaking, that using a lower target for partial pressure of arterial PaO, or the PaO2, would result in lower mortality than using a higher target. Now, this was interesting. This slide sort of caught my attention, and I was trying to figure out 60 to 90, what is the actual difference in oxygen content? But of course, I'm not really sure, and I'll go through all these slides, and I'll kind of say this again. I'm not really sure if what this is about is the PaO2 being lower or higher, but what you have to accomplish, or what you have to do, meaning higher inspired O2, in order to achieve that higher PaO2. And I think it's so multifactorial. It was a good paper. I recommend you reading it, but it left me a little bit with more questions than it did necessarily give me answers, and I'll explain a little bit more about my quandaries with this as we move forward. In one different article, a small multi-center randomized trial involving patients undergoing mechanical ventilation in the ICU, those investigators, now that's not these investigators, we're talking about a different presentation or different paper now, found that targeting a peripheral oxygen saturation of between 88 to 92% as compared with a value of 96% or above was feasible without evident harm. Again, we can discuss that as we go forward. In a single center randomized trial, this is yet a different paper, patients in the ICU who were treated with a PaO2 target of between 70 to 80 millimeters of mercury had a lower mortality than those who were treated with a PaO2 target of up to 150 millimeters of mercury. In addition, a PaO2 target of 55 to 80 millimeters of mercury is often referred to as the standard of care in patients with acute respiratory distress syndrome, or ARDS, as it was described in several trials performed by the actual ARDS network. The preference among clinicians for a lower oxygen target in the ICU has been confirmed in a multinational survey in which 80% of the respondents would accept a PaO2 target of 60 or lower in clinical trials. So here are all of the references for the papers that I just talked about in brief. And I also want to talk about, again, the issue of, is it accepting the lower PaO2 for the PaO2's sake, or to reduce the amount of inspired, or the percentage of inspired oxygen that you have to give the patient? And how does that interact with ECMO when you take that aspect part of it and add it to it? And so, we all know, and not to be too rudimentary, but we all understand that high inspired oxygen via the ventilator or otherwise long term is detrimental to the lung tissue, the alveolar tissue itself. And of course, you can also have ocular issues, ocular problems that can occur as well. So high inspired oxygen content is not something that's good. We're designed to live off 21%. That's how our physiology is made, right? Recently, a systemic review and meta-analysis showed that lower oxygenation targets were preferable in acutely ill patients. Again, I don't think I really agree with this, not on that merit. On the reducing the inspired oxygen content, yes, but having a lower oxygen target, I'm not so sure I agree with, and I'll explain again as we move forward. However, the liberal oxygenation versus conservative oxygenation in ARDS trial, which is LOCO-2, was stopped prematurely because of a higher frequency of mesenteric ischemia and a higher 90-day mortality in the lower oxygen group than in the higher oxygen group. Now, was that because the lower oxygen group required maybe more pressors, Levophed, higher amount? I don't have an answer to that, but something to be concerned about. Or it could have just been physiologic, responding to a lower oxygen content or oxygen delivery, DO2, of that patient. In the large intensive care unit randomized trial comparing two approaches to oxygen therapy, the ICU ROC study as it's known, investigators found no between group differences in the number of ventilator-free days or in mortality within 28 days, with higher versus lower, again, PO2 values. And here are the references for those particular studies that were done. So I know we've all seen this before. We all understand. In fact, John Ingram did a great presentation on the oxyhemoglobin dissociation curve. But I want to go over it again so that we're all just sort of on the same page with this. If you look at, for example, a PO2, we're going to say down here of 50. I'm sorry, yeah, PO2 of 50. A PO2 of 50 following this line up is a saturation of about 88%. And if you look at this dissociation curve, you notice that as the PO2, or the saturation climbs, you notice how steep a curve it is for these lower PO2 values. But as you get up towards the top of the saturation, this curve really flattens out. So, and if you'll excuse me all for just 1 second. Is everything okay? Yeah. I'm sorry, forgive me, everybody. Okay, good. Thank you. So it's really important to take note that the oxyhemoglobin dissociation curve is very sharp in the beginning and then flattens out as your saturation reaches about 85, 88% up until you get to 100%. And there's very little continued increase in the saturation for the PO2 going up. And why is that? And this is also very, very important. Oxygen content, the thing we're really concerned about, is your SaO2, your saturation, arterial saturation, times 1.34 times the hemoglobin, but plus 0.003 times the PO2 measured in milliliters per deciliter. So you're understanding that the contribution of the blood, the PO2, the blood measured, hold on one second, guys, I'm sorry. Can I can't, is everything okay? I mean, I'm sorry, thank you. It's really, I don't know what you're saying. Well, I can't, okay, I won't look at you, but I can hear you if you can help me out. Anyway, what I was trying to say is that there's very little oxygen dissolved in the plasma. You really need to be concerned about the saturation. That's what's important, because the hemoglobin carries so much more oxygen, is so much larger a contributor to the overall oxygen content. So that's very important for y'all to understand. So here is a breakdown of the patients. There was a total of 4,192 that were assessed for eligibility. I won't go through all of the exclusions. 2,928 were randomized. 1,462 were assigned to the lower oxygen group, 1,466 to the higher oxygen group. And when it was all said and done, 1,441 were analyzed in the lower, and 1,447 were analyzed in the higher oxygen content group. You keep looking at me, making me nervous. Okay, and here are the characteristics. And what I was really impressed by was the homogeneity of the characteristics. They were very, very, very closely matched. So that was really good. In the lower oxygen content group, the invasive ventilation, again, I had to take note of the fact that I felt like everything was very well matched and very similar. And again, with the lactate levels, the use of inotropes, patient percentage, median highest dose of norepinephrine, all very closely matched, and the median SOFA score was also very closely matched. So I was very impressed with how closely they matched all of these patients. In terms of oxygenation and ICU intervention, the use of mechanical ventilation, prone positioning, inhaled vasodilators, the use of ECMO, circulatory support, renal replacement therapy, and blood transfusions were similar in the two groups. And again, I showed you those graphs, all of that data. It was very closely matched. I was very impressed by that. In this particular slide, the red is the higher PO2 group, and the blue is the lower oxygenation group. And you can see that as you go along what their ranges were. So it ranged quite a bit, especially when you started getting out to day 60, 70, 80, and 90. And what's very interesting, that in the lower oxygen tension group that was assigned to it, there's actually sometimes when it's higher than that of the higher oxygen content group, or higher oxygenation group. And I think that's because those patients were were struggling at that point in time. It seemed to start out pretty easy, but then as time went on, these patients became, I think, more and more difficult to manage. The fraction of inspired oxygen, and what I just got through saying, I think bears out in this, where you see the lower oxygen group started needing a higher towards the, when you get back out here to the end. Let me see if I can do the laser right here. You start looking out this way, and you'll notice that the FiO2, your inspired FiO2, had to start going up on some of these patients, whereas with the higher, it started going down. And that may have been an indication of survival. I'm not really sure, but their survival really in this study was similar in the groups. We'll talk about their conclusions. The arterial oxygen saturation, it trends just like the PaO2 does, which you see there. And so much of that can be affected by the patient's cardiac output, their metabolic rate, their level of sedation, whether they're on paralytics, their temperature. So many things are going to affect and contribute to these numbers that we're looking at. Though I think they did a great job of case matching, I think there's a lot of unanswered questions on any one of these individual cases. Primary outcomes, if you look at the outcomes, you'll see over here in the p-values for everything from death to percentage of days alive without life support to serious adverse events, shock, myocardial ischemia, ischemic stroke, intestinal ischemia. You'll note that there is no statistical difference between the lower or the higher oxygen content groups. And indeed, when you look at their results, and this is directly from their paper, at 90 days, 618 of 1,441 patients, 42.9%, in the lower oxygen group, and 613 of 1,447, remember they had a little higher, or 14.4% in the higher oxygen content group, had died. So risk of mortality, just based on that, is absolutely no different. The adjusted risk ratio is 1.02 with a 95% confidence interval, CI, and at 90 days, there was no significant between group difference in the percentage of days that patients were alive without life support, or in the percentage of days they were alive after hospital discharge. The percentage of the patients who had new episodes of shock, myocardial ischemia, ischemic stroke, or intestinal ischemia were similar as well in both groups, with a p-value of 0.24. And in their conclusion, among adult patients with acute hypoxic respiratory failure in the ICU, a lower oxygen target did not result in lower mortality than a higher target at 90 days. So some of my individual concerns, no data was available to differentiate between ECMO and non-ECMO patients, because that's going to make an enormous difference. How you're managing the ventilator and what you can do with when you're on ECMO versus not on ECMO is vastly different. Not to mention, on ECMO carries its own set of, quite serious morbidity risks. What was the cannulation strategy? Was it VV or VA, or was it some kind of exotic cannulation? Where were the ABGs drawn from? That's also very important. If you're VA ECMO and you're drawing it from the contralateral, let's say with peripheral cannulation, and you're drawing it from the contralateral femoral artery, your numbers may look great. If you're drawing it from the left radial, you may actually think you're right within the guidelines of the lower oxygen group, but if you're drawing it from the right radial, it could be significantly higher depending on what your underlying cardiac function is. Are you centrally cannulated, which of course that would make a whole big difference, or cannulated in the axillary? There's so many different things that did not get answered in this, and so I will say that though a great study, I think we have to look at it a little bit, even though I think their outcomes mimic what I would expect. And I'll talk more about my view on lower versus higher oxygen content here in just a moment. No data to differentiate between CRRT and non-CRRT patients. No data to differentiate between nitrous oxide versus non-nitrous oxide. No cardiac output and DO2 vis-a-vis goal-directed therapy was assessed in this. And ELSO guidelines actually recommend a target SaO2 of 80 to 85% at rest ventilator settings, so long as cardiac output and hemoglobin levels are adequate. And what that really means to me isn't that cardiac output and hemoglobin levels are adequate. What does that actually mean? I think it really comes down to DO2. I think the key to managing patients that are critically ill to give them the best opportunity for survival is DO2. The three best is DO2, DO2, and DO2. I think that's very important. I frankly think 80 to 85% for saturation is just a little bit too low. In fact, if you look at that, let me just go right back to this slide. A saturation of 80% that we look at here is going to give you a PO2 somewhere around 42 to 44% PO2. I'm sorry, 42 to 44. You know, that's pretty low, and I'm going to talk about these numbers here with the app. Let me do this first. There was another study that I found which was very good in the Journal of Thoracic Disease, bedside troubleshooting during venous extrapulmonary membrane oxygenation. Now, as a disclaimer, I'm going to tell you that if you look at the red dash, and I'll highlight it right here, and you see it says filter dysfunction, and you see here it says change filter, they mean oxygenator. It about drives me crazy when people talk about the oxygenator and call it a filter. It's not a filter. It is an oxygenator. It's essentially an external artificial lung, a gas exchange device that adds oxygen and removes CO2. So I think that that's something that may have just been vernacular. I'm not sure where these authors were located, but that could just be a language thing. But it is a glaring improper syntax, if you will. No, maybe not syntax. It's the improper word to use for the oxygenator. So if you look at a chest X-ray and ABG and it suggests cannula malpositioning or recirculation, you look at the X-ray and you see the cannula, if you're using single cannula, is all the way down into the area of the liver. It's probably in too deep. You can sometimes look at the tubing and you can run a venous blood gas coming out of the line, and if it's very high, certainly going to be suggestive of, in fact, if it's 88% or higher, I guess, it's very suggestive that you have recirculation. But there is a much better way to do it, and that is with the use of the transonic ELSA. It will give you you can run 3 of them. I think that it makes sense to do that. Back in the old days when we did thermal dilution swans, we always ran 3. You can run 3 of these. It's going to cost you about 60 cc's of volume into the patient, 20 cc's each injection, and the ELSA meter is very useful at giving you not only recirculation, but oxygenator blood volume. So if you're using a low heparinization protocol or no heparin, no anticoagulant strategy, it'll give you oxygenator blood volume, because if the oxygenator blood volume goes down, the only thing that could be occupying that space is, in fact, clot. But if the answer is yes, then they say to come over here and reposition the cannulas, if cannula or cannulas. If you have persistent hypoxemia, then you go over here and you consider, is there oxygenator dysfunction, further lung complications, or low pre-oxygen oxygenator SaO2, and that could be because of low cardiac output, which is a real problem, or very high extraction. If that is the case, and the problem is not resolved, but you think it is oxygenator dysfunction, you can change the oxygenator. You can treat the specific complications by possibly slowing down the metabolic needs of the patient, reducing the temperature a little bit, anesthetizing or sedating them heavier. You can do some things to increase the DO2. Maybe they need a blood transfusion, higher hemoglobin. Maybe they need a little bit better cardiac output, and they need a little Dobutrex or something like that. There's a lot of options that you can consider, but you have to look at it. You know, you can't just look at one thing. You have to take everything into consideration as far as what's going on with the patient at this moment, right? If you have persistent hypoxemia, let's see if I can make this work. Yeah. Then you come over here and you increase the ECMO flow up to 6 or 7 liters. If it stays persistent and your hemoglobin is less than 10, consider a transfusion, which is here. If the answer is no, then you might have to take into consideration what if it's VV ECMO. Now this is VV ECMO. If your ECMO flow and your cardiac output ratio is less than 60%. And so what happens in this circumstance, a very important concept, if you're VV ECMO and you're flowing 5 liters, but the cardiac output is 10 liters, and the patient has no significant contribution of their native pulmonary function, their pulmonary function is very minimal at best, then you're only going to be running through the oxygenator 50% of their cardiac output. So as that, with some level of recirculation, it's never zero. So if you're flowing 5 liters, you're recirculating, let's say 20%, which would be fantastic. That's going to be 1 liter. So you have an effective ECMO flow of 4, and your cardiac output is 10 liters or 8 liters. You can, and your venous saturation is 65%. You can easily see where that's going to then mix together, and that's what's going to end up in the left atrium and left ventricle and be pumped back out to the systemic circulation. So when you draw a gas and you say, I'm flowing 5 liters and I'm at 100% and my ECMO saturation is 100% with a PaO2 of 360, why is the patient's saturation only 89%? It could very well be that your ECMO flow to cardiac output ratio is too large. So sometimes slowing the cardiac function down is a better option if the patient is getting sufficient DO2. If the hypoxemia is resolved here, then monitor for hemolysis because of the high flows. If this is no, then consider, I'm not sure what PP is. Yeah, I'm not sure. And then if it's yes, you come over here and consider hypothermia, or you consider using esmolol, a good beta blocker, as I said. So that's very good. It's very short acting, and it will really slow them down. I wonder if I have that in my notes. No, I don't. Okay, very good. So I want to go to the app if I can, and I want to illustrate for you the importance of your DO2. So is it married to it yet? Is it still married to it, or I need to do it again? Screen mirroring. Okay. Did it come up? Oh, good. Okay. But I don't see it. Oh, there it goes. Okay. So now, okay, so if we take in this particular case, and I have it already done, so I'll just hit calculate again. If we take a hemoglobin of 10, which I guess I can't really show you, can I? So you take a hemoglobin of 10, you take an SaO2 of 85% and a PaO2 of 50%. That's going to give you an oxygen content, arterial oxygen content of 11.71 milliliters per deciliter, okay? So for the sake of just this argument, because none of this will make sense, right, if I did this, if I doubled the PaO2 to 100, now you couldn't have a PaO2 of 100 with a saturation of 85%, but I'm going to do this for the sake of the argument. It only moves it up to 11.87. But if I go over here and I change the saturation to 100% from 85, 13.91. Now, what does that really mean? Well, okay, if I take DO2, which is here, delivery of oxygen, I put a cardiac output in of 5 liters per minute, and I put in 11.71 for my oxygen content from the very beginning, if you remember. That gives me a DO2 of 585, which if you notice on the app, it's showing up as red because it's abnormal. And up here where the I is that I'm going to press, that actually gives you the upper right corner all of the parameters, the equation, and what is normal. But if I change this to the 13.9, all things remaining equal, it's still abnormal, but it's 695, which is significantly different than the small little incremental change of the 11.87. And if I just do it for the sake of that argument, 11.87, which was, if you remember, doubling the PO2, that only takes it from 585 to 593. So you see how important saturation is, and if you go back to that formula that we discussed, and this is key, the saturation is 1.34 times the hemoglobin. The PO2 is only 0.003 times the measured PO2 in millimeters of mercury, which is in milliliters per deciliter, which is the result that you'll get. So the amount of content that's dissolved in the plasma is very, very, very low in comparison to that is bound to the hemoglobin. And that's why hemoglobin is so critically important for DO2, for delivering oxygen. I think we run hemoglobins too low, and I would really like to see them be higher. But, you know, it depends on the practice. It depends on a lot of factors. It depends on the age of the patient. Depends on the metabolic condition of the patient. Depends on the function of their heart. A lot of factors influence whether we should use a higher or lower hemoglobin. And those arguments have been made as well, where they have done low oxygen or low hemoglobin transfusion trigger down in the 6 range, and liberal, which keeps the hemoglobin up around 10. There are risks and complications associated with giving patients blood transfusions, certainly recognize that as well. But from a risk-benefit ratio perspective, I think patients do better from what my eyeballs tell me, not from the data, do better with a higher hemoglobin than they do with a lower hemoglobin. That's my professional observation over many years looking at many critically ill patients. So that's my preference, though the data does not support that. I have to, you know, obviously make that clear. But I think sometimes the data is good, but I think it sometimes doesn't take into account a lot of individualization when you're dealing with patients. This patient and that patient, though they may look matched demographically or with their you know, various parameters that you may be measuring, doesn't really mean they're the same patient. So I think we have to take these things into consideration when we make the decision about how high or how low to allow the hemoglobin to be or to go, as the case may be. Okay, are there anybody who wants to call in? You didn't open the phone lines. So, oh, they are. Were they been open the whole time? I saw you push a button over there. Is that, it wasn't on, was it? Magic, did you find a nurse yet? Looking. Okay, good. We're still looking for a nurse. The phone lines are open. I'm going to take a short break, maybe 2 or 3 minutes, not very long, come back and do my second lecture, and if we have any good questions on FaceTime or Twitter or LinkedIn or YouTube, or somebody wants to call in, don't forget we've got the hat, we have the cap, we have the, what did they win, the cup? Do you remember? The cup, okay. Oh, it was the cup. The cap, an extra call, okay. And we might even spin it again for the T-shirt, if again, but you got to call in. And this is some pretty stylish stuff. So I think you should call in. I also think you need to find the transonic ELSA-meter, and I think you need to find out more about it. If you are doing ECMO, you should absolutely have that device. No question about it. I believe in it. I have used it. I wish I had more of them, but you don't have to leave it in one patient's room. You can take it patient to patient, as the case may be. But I think you should at least evaluate the device because I think it has tremendous utility, a great tool. And I think you should go on the Apple Store or go on the Google Play and get that MediWeb app, because I'm going to tell you, it's a really good tool. As I said, I do a lot of ECMO, and I use this tool. It even has a calculation in there. And one of my good friends, Sharon Kroslowitz, she just got through teaching one of our young new hires from Rush. Her name is Ramsha. I'll just say her name. Her name is Ramsha Asmat, and she is doing fantastic. She actually did a case yesterday. She is extremely smart, very, very talented. She tolerates me more than the guys here in the over in the workings do, and put up with my nonsense. But she's fantastic, and she was teaching her the formula for deciding how long you can go on your e-cylinder tank. And I'm like, Sharon, it's in the app. It's just in the app. If you go to the app and you go to O2 remaining in e-cylinder, we've thought of everything. It's a good app. Go check it out. It's $2.99 for the big app, $99 for the small app. If you just need it for IV drug use, dosing, and so forth. But either way, check it out. And we'll take a 5-minute break, and let's say 5 minutes. And I'll be right back for my second half of this. Thank you. Hello and welcome back, everyone, to PerfWeb. We're going to jump right into our second lecture, which is going to be V-A ECMO, Predicting Survival with SAVE, which is an acronym for Survival After Veno-Arterial ECMO. This is published in the European Society of Cardiology in 2015, and if you notice the lead author, Matthew Schmidt, he was also involved in the V-A ECMO preserve at RESP and preserve scores, and I talked about that, I think, not too terribly long ago. I do want to take sort of a side trail if we can, and we're really having a dispute here in the studio, and it's just myself, it's Magic, our producer, and then it's David, our editor and production director, and we're discussing who works harder. And Magic is our resident person from Poland. I guess that's okay to say. I'm not sure. And he thinks he works the hardest. I, for a moment, thought I worked the hardest. And believe me, that for the past year, this has been absolutely horrifying as far as I'm concerned, with caseload and with COVID and with ECMOs and very sick patients. Very demoralizing, actually. A lot of bad outcomes, and we'll talk about that actually in this study. It's very important. And then we have, as I said, David. He's just a Texan, but I've come to the conclusion that neither David nor Magic nor myself works the hardest. I'll tell you who works the hardest is Tammy Sparacino. She actually works the hardest. She's actually the manager of HET, and let me tell you what, we have had a rough year, but she has done just an incredible job taking over that role in the height of a pandemic during the worst possible time, and has more than risen to the occasion. So I'm going to give Tammy Sparacino, who is also a Texan, not only a Texan, but a Houstonian Texan, all of the credit for working the hardest of anyone. I'll give myself and David the next hardest workers, and then Magic, the person from Poland. That's PC, right? Politically correct person from Poland. I guess I should. What pronoun do you want to use, Magic? Which do you prefer? He, she, I'm not sure. Her, him, I'm not 100% sure. Okay, V-A ECMO, Predicting Survival with SAVE. This is very important. And we are trying to hire a nurse. And you can call Magic at, I don't know, what number do you want them to use? If you could put that up on the screen.
Yeah, they find me anywhere.
Find him anywhere. Okay, I'll let your wife know that. You can find Magic anywhere, apparently. Okay. Back to the slides. Veno-Arterial extracorporeal membrane oxygenation, also known as V-A ECMO, and I will correct something here. If you look at this, it says V-A ECMO. It looks like Veterans Association, Veterans Administration. I'm sorry, ECMO. The dash, whenever you write this kind of thing, and John Ingram actually taught us this, if it's V-A, it's wherever the dash is where the oxygenator is. Okay? So Veno-Arterial. So VA really doesn't tell you anything, and then dash ECMO. So it would be VA V-A space ECMO would be the correct way to write this. Is an effective technique to support refractory cardiogenic shock while ensuring continuous organ perfusion to wait for cardiac function recovery, transplantation, or durable VAD. So basically, or total artificial heart. So basically, VA ECMO and V-A ECMO is similar in the regards to it is a bridge. It is either a bridge to recovery, it is a bridge to a transplant, it's a bridge to a durable ventricular assist device or artificial heart or lung, as I said, transplant, lung transplant in the case of lungs. There is no long-term device that they have for that. or it is a bridge to decision. And sometimes that decision is to stop the therapy. When the patient has no exit strategy, they're not a candidate for transplantation. They're not a candidate for a durable VAD or total artificial heart. Their lungs aren't going to recover, and the ECMO, in that case VV, but it could also be VA, can keep that patient not only their organs alive, but neurologically intact. And it's very scary, and it's very emotionally taxing to be dealing with these patients. There are several articles out there, and I know people who have actually had awake patients who themselves decided, since there was no exit for them and their life was limited to being tethered to this machine, external device, whether it be VA or VV ECMO, and they have been the decision maker to go ahead and let's turn this off now, knowing full well that was going to be the end of their life. It's very, very difficult, but it's a reality. We've become so incredibly good at keeping the overall organism alive, dealing with all of their other things, whether it be pulmonary and oxygenation or circulation, and keeping their kidneys going. We can even add CRRT if they start going into renal failure. It doesn't matter. We have another machine for that. Our technology has, in many ways, exceeded the body's ability to heal, and so it's been a trying time. COVID has really been as I said, I've said it before. I sometimes say it a little tongue-in-cheek, kind of. What was that called? Graveyard humor or something like that. I forgot there's a term for that. I don't remember. That's not it, but it's similar. Because that's our defense mechanism. It's been very difficult year for us with COVID. Compared to even H1N1, our outcomes have been much, much less rewarding. So I'm very, it's a very interesting thing, and I'm going to be very interested to see what the long-term results of all of this are on a more international scale. Most frequent indications for Veno-Arterial ECMO or full cardiopulmonary circulatory support, mechanical circulatory support. It comes with a whole different, cornucopia of flavors or acronyms or whatever you want to call it. Include fulminant myocarditis, acute myocardial infarction, post-heart transplantation, and post-cardiotomy. And if you'll excuse me, when they say post-cardiotomy, that really means failure to wean off of cardiopulmonary bypass after having heart surgery. And forgive me, I'm sorry, I just needed to answer that text real fast. So when you do a coronary or you do a valve coronary, whatever the case may be, and you can't wean from bypass, sometimes you'll have right heart dysfunction. In fact, I just saw that today. I was down at the medical center and watching somebody do a case, and they had transitioned from cardiopulmonary bypass to VA ECMO for right heart dysfunction, which that will be a bridge to recovery. 2-3 days, that right heart should come back. But it does happen. Despite significant advances in VA ECMO, and that's what we're talking about here, there is a high complication rate. Bleeding, absolutely number one. Infection is always a big problem. And device failure and complications of the device itself, which could be a variety of different things. That's not very common, however, for the oxygenator to fail. Now, you could be using, for example, there are two different kinds of ECMOs, right? There's polypropylene membranes or microporous hollow fiber designs. There's PMP or polymethylpentene, which tends to last longer, that doesn't react with lipids. If you have somebody on VA ECMO and you are giving them propofol or they're severely hyperlipidemic, you can have membrane wetting, which it's called, and then it starts foaming and you can't blow off your CO2 and you have to change it. Patient's very unstable, they don't tolerate the change. That would be considered a device failure, but it's really, that's more of a perhaps what you had at the time to do what you had to do, or a clinical decision that was based on what was believed to be the best practice, and it still failed. That can happen. You can have, it's more likely somebody is going to inadvertently break a connector off. You try to build these systems and design them to minimize that risk, but that can happen. You can have the centrifugal pumps get very hot, and you could have a bearing failure or something like that. Certainly that can happen. But again, bleeding and infection, the top two by far. Device failure and complications directly associated to the device are really very low. Long-term physical and psychological impairment is huge and really not considered by the initial clinicians that are managing these patients, especially the ones making the decision to put these patients on. There was a study by an Italian physician and colleagues that long-term functional and psychological recovery in a population of both ARDS patients treated with VV ECMO and VA ECMO and their caregivers at almost a 3-year follow-up. ARDS survivors treated with VV ECMO showed reduced health-related quality of life and high risk of psychological impairment, in particular PTSD. Caregivers of this population were also at high psychological risk. And I think that is very much not taken into consideration. Patients put on ECMO tend to be there for quite a long time. And it is of course, it's so rewarding when somebody does, in fact, transition off of ECMO bridge to recovery, or they go get that transplant. But if they're not eligible for transplant and they aren't going to recover, it can be a long affair, and you can, I think that the clinicians that are managing these patients, including myself, have been significantly affected by the amount of, or the lack of positive outcomes, I'll put it that way, that we have seen during this pandemic. It's been very demoralizing, to be quite frank with you. In another article in Intensive Care and Critical Care Nursing, the psychological and health-related quality of life-related aftermaths of extracorporeal membrane oxygenation treatment for patients with VA ECMO also showed very similar deep-seated psychological impairment, PTSD-like issues with these patients and caregivers. So the aim of the study, the SAVE study, is to identify pre-ECMO factors that predict survival. So using a large international cohort of 3,800 plus patients treated with ECMO for cardiogenic shock. Now remember, we're talking VA ECMO with the SAVE score. Okay? They identified prognostic factors for hospital survival and created what they termed as a well-calibrated and discriminatory survival prediction score, comprising 13 pre-ECMO variables. The survival after Veno-Arterial ECMO, or the SAVE score, and that's what this is about. It is the first validated international predictive mortality model based on a large population of acute refractory cardiogenic shock patients requiring ECMO. Based on these findings, the SAVE score and its online calculator, which we'll go over, you can find it at www.save-score.com, offer a validated tool to predict survival for patients receiving ECMO for refractory cardiogenic shock. Now, that's a real strong statement, and this was written, of course, by the authors. I didn't read it quoting it, but I paraphrased it to some degree. It's still very bold. We're going to go over it and talk about it and look at it and take it into consideration. and discuss its validity as a tool. So the rationale, development of a prediction score for VA ECMO survival. This includes decision, management, and then comparison. The methods and results between January 2003 and December 2013, they extracted data from the ELSO registry, which, as you know, is a multi-center international database or registry. They selected 3,800 plus total patients with cardiogenic shock treated with ECMO. 1,601 of those patients, or 42%, were alive at discharge. And actually, this is where the consult, the informed consent, if you will, comes from, is this actual information from ELSO. When you are quoting to a family what their chances of survival are with VA ECMO, they usually say it's about 40%. VV ECMO, it's about 60%. And this is where these numbers come from. But just because the overall is 42% doesn't mean this individual patient has a 42% chance of survival. Again, you really have to look, with VA ECMO, you really have to look at the patient that you're in front of at the moment. Independent risk factors for mortality, chronic renal failure obviously is a big one. Longer duration event prior to ECMO. I'm not sure why that plays that big of a role in VA ECMO versus VV ECMO, but it is on there. Multi-organ failure, obviously that's obvious. Pre-ECMO cardiac arrest, well, you know, I mean, those are the stories that we all love, you know. I mean, we see them, I've seen them on YouTube, where the guy was at home, or he was at work, or he was at the grocery store, and grabs his chest and goes down, and some person, you know, comes to the rescue and starts doing CPR because they learned how to do it, which is great. And they get transported to the hospital, and they had acute occlusion of the LAD, and they got that corrected. And the next thing you know, well, they put him on VA ECMO, and then they took him from the emergency room. Then they took him to the cath lab. Then they took him to the operating room. Then he came out, and he got his life back. Those are the saves. Those are the great cases. So, but yeah, pre-ECMO cardiac arrest. But a lot of times these people are going on VA ECMO because of pre-ECMO cardiac arrest. Congenital disease is obviously a big problem. Lower pulse pressure and lower bicarb levels are all independent risk factors of mortality. And I would say lower pulse pressure, you know, unless they're PEA, of course, they're going to have nothing. But if they're lower HCO3, that could be the duration of the code. That could be a lack of sufficient bicarb to correct how the code was run. There could be a lot of factors involved. But I'm assuming that all of this really means the longer you go to make your decision, the worse off you're going to be, because that's, you know, not having circulatory support for a long time and just doing CPR for a long time is not really good for you. But I've seen some patients who have had CPR for over an hour. I've seen 2 hours, and have been finally put on VA ECMO, and I've seen patients survive it when I never thought they even had a chance to, but they did. So you just don't know. You have to, again, you have to take into consideration the patient that you're dealing with. If it's an 83-year-old or 76-year-old frail person with a relatively unhealthy lifestyle, and they have diabetes, and they have some renal insufficiency, notwithstanding chronic renal failure, but they have actual just renal insufficiency, renal disease, somewhat of a vascular path, and you have a 52-year-old who maybe he is a little bit overweight, but he doesn't have all these other issues going on, well, you know, likelihood is the 52-year-old's probably got the better chance than the 73-year-old. But I've seen it where the 73-year-old made it and the 50-year-old didn't. So again, you just really don't know. Factors favoring survival: younger age, lower weight, acute myocarditis, heart transplant, refractory VT-VF. So if you have If you have PEA, that's bad. If you have VT, VF, you're much better off, much higher chance of survival. Higher diastolic pressure, but of course, was that with drugs, without drugs, what drugs, and so forth, balloon pump, how is that being measured? I'm not really sure. And lower peak inspiratory pressure. The external validation to this comes from the Australian population. That's where this study was done. 161 patients between July 1st of 2006 to December 31st of 2013, and it was at the Alfred Hospital in Melbourne, Australia. You remember the RESP score also comes from there. Preserve came from, or the validation to RESP and Preserve, I believe, was something different. So RESP and Preserve, Preserve was in France, RESP was in Australia, and or ELSO, but the validation was in France. I don't remember exactly, but a lot goes on at the Alfred Hospital in Melbourne, Australia. This much I'll tell you. They publish a lot of stuff. So here on the left, you see the derivation cohort, and then on the right, you see the validation cohort. So the one on the left is basically from the ELSO database. The one on the right is from the Alfred Hospital in Melbourne. And you see the N3846, 42% alive, and 58% did not survive. In the validation cohort, 67% were alive, and only 33% were dead, based on the what developed the SAVE score and based on the SAVE score. So we need to really explore this, because that from 67% to 42% is huge, and that's an incredible difference. So we need to see what did they do to have such better outcomes. Okay, this I don't need to mention that. And this is from the European, by the way, Society of Cardiology. That same journal. What did I do? Okay. Okay, so hospital survival rate in the most prevalent diagnostic groups: acute MI, valvular heart disease, other causes of cardiogenic shock and sepsis, and in diagnostic groups independently related to survival: myocarditis, heart and lung transplant, refractory VF-VT, cardiac arrest prior to extracorporeal membrane, and congenital heart disease. According to the survival after VA ECMO risk category at extracorporeal membrane oxygenation initiation. So this is the score prior to the decision to put the patient on ECMO. So equal to or less than 10 is risk category 5. If you're minus 9.5 to minus 9 to minus 5, you're risk category 4. Minus 4 to 0, you're risk category 3. 1 to 5 on the positive scale, you're risk category 2, and greater than 5, you are risk category 1. So if we look here, here are the parameters and here are the scores. So let's just go ahead and do this. Let's say the patient has, we're going to give, so myocarditis is the best because you can see the score's 3, but I'm going to give this patient refractory VT-VF, so I'm going to give them a 2. Their age, we're going to make this patient 62 years old. So let's do that. So we're going to give them a 3. So we're up to 5. Weight, we're going to say the patient is greater than 90 kilograms because that's more common. So that's going to be plus 0. So we're still at 5. Okay? So I'll carry my 5 over. Acute pre-ECMO organ failures, select 1 or more if required. So we're going to say the patient does have renal failure. They're anuric. We just say they're either an acute renal failure or they're in acute kidney injury, AKI. So we're going to give them a -3. So now we're at a 2. Duration of intubation prior to initiation of ECMO, we're going to say it was less than 10 hours. So we're going to give them a 0. So I did that. I did this. So 0. So we're still at 2. Pre-ECMO cardiac arrest, -2. We're at 0. Diastolic blood pressure before ECMO greater than 40, or pulse pressure before ECMO. So we're going to say, let's say the bicarb value was less than 15. So we're going to say -3. So now we're at -3. Okay. And the total score can be -35 to 7. Okay, constant value to add to all calculations of SAVE scores, a -6. So that's going to be now -9. So -3 plus -6 equals -9. So we'll go to the next slide. So we're at -9 based on what I've added into this. So that is going to be a SAVE score of 4, which is pretty doggone high, okay? Or, you know, that's a lot for that, because that's not an unusual patient. So let's go over here and look at survival. So if they are going to be in class, I have to go back here, forgive me. So -9 is going to be class 4, okay? So they are a class 4. So I'll put class 4 for our patient, class 4. And that is going to be right here. And in the predicted survival, they're going to be right at 30%. And you can see it right there. With the SAVE score, however, same class 4, they are going to have a survival of 62%. That is a dramatic difference. Hospital survival percentage in derivation cohort according to the survival after VA ECMO or the SAVE score at extrapulmonary oxygenation initiation for severe cardiogenic shock. Hospital survival percentage in the validation cohort according to the survival or the SAVE score. Survival percentage is expressed as the mean plus or minus the standard deviation number of patients in the study had particular survival after VA ECMO. Point being, the derivation cohort would say a 30% survival, and in the Alfred Hospital's hands, they had a survival of 62%. That is a major, major difference, and that can be a variety of reasons. One of those reasons, and I think probably the highest contributor to this, is because in the large multi-center international study, you are not going to have the same way of managing these patients across all of these particular populations. Some are going to use different cannulation strategies. Some are going to use different hemoglobin strategies. Some are going to use different oxygen content or PO2 strategies. Some are going to use different ventilatory strategies. Some are going to use different types of membranes. Some are going to use, some are going to treat with CRRT. Some are not going to treat with CRRT. Some are going to integrate CRRT into the dialysis, or to the ECMO circuit. Some are going to try to do it with introducing another catheter. Anticoagulation strategies. Some are going to do high anticoagulation, low anticoagulation, no anticoagulation, Angiomax, heparin, Plavix and aspirin, you name it. So there's so many factors involved, but it is important, very important for me to at least say that the difference in predicted survival based on the ELSO criteria and the predicted survival via the SAVE score is remarkably different. So here you have hospital survival in the most prevalent diagnostic groups. Here you have the SAVE score 1. You have a survival with myocarditis of 76%, heart and lung transplant, 76% going down the list. Valvular heart disease, cardiac arrest, you can see that there. And if you're class 4, you have, for these things, you have a survival of this. Okay. Here is the online calculator. Let's see, can I make that work? How do I make that work? No, you can't just tap it and make it work. I didn't make it a link, no. Okay, so let me just go to a, let me go here. Save, score, ECMO. There we go. There it is. Cool, okay. So we're going to go age 53 to 62. Sorry. Okay, myocarditis, no. Refractory VFVT, no on transplant, no on congenital. Other diagnosis, everybody has another diagnosis. 52 to 63 years old, weight is greater than 90 kilograms. And you see over here how it's moving. You see the red bar, I don't know if you can see it. Your pulse pressure is equal to or less than 20. I'll say yes. Pre-ECMO cardiac arrest, yes. Peak inspiratory pressure, no. Intubation, less than 10 hours, less than or equal to. Acute renal failure, yes. And bicarb less than 15. But look at that. And I'm doing the same thing, but I'm getting a different number. Maybe my math was messed up. Other organ failure, it showed it on their own publication. Other organ failures, pre-ECMO, central nervous system dysfunction, no. Liver failure, we'll say yeah. So you have all these problems. You have a survival of somewhere between, according to SAVE, 15%, well, it can range anywhere from 0 to 35% with a mean of somewhere around 15%. If I take this bicarb problem away, and let's say they didn't have that as an issue, you get a little bit better. I'm going to take the renal failure away, which is here. Oh, I didn't put, yeah, right here. There you go. Take that away. You're getting a little bit better. Now you're up about 25%. We'll take the liver failure away. You're up to about 32%. We'll say that your pulse pressure pre-ECMO was greater than 20, so you're up to almost 48%. I'm going to make you a little bit younger, and you go up even higher. And we're going to take away this and say it was myocarditis, and it's even a little bit higher still. So you see you can play with this SAVE score. So your SAVE score in this case is -1. And so the lower that number, or the more minus that number, the worse your outcomes are going to be. Okay? Discussion points. Very large discrepancy of outcomes with the derivation versus the validation cohorts. And I just talked about why I think that is. Major technological changes have occurred and technique changes since 2003, even through 2013. We do more LV venting with the Impella now, which I think reduces LV wall tension and helps preserve that heart, helps it recover quite a bit. And we have managed this, the coagulopathies and the bleeding complications, and actually it's just bleeding complications from anticoagulation. I don't think it's coagulopathy. It's just bleeding. The coagulopathy comes from the transfusions we have to do because we keep bleeding out their clotting factors and their hemoglobin, of course. So low to no anticoagulation strategies, I think, have helped a great deal in this regard. I think there are a lack of controlled protocols. I say this a lot, and I mean it. Just because you can, there's a big difference between whether you can and you should or you should not. And that's very important. I really think when you look at long-term survivals, getting people off of VA ECMO and weaning them from it is not survival. It's survival from ECMO, But survival to me means you walk out of the hospital and you have an acceptable to you, whatever acceptability is to you. That's, I understand, very subjective. Health-related quality of life. You have to just take that into consideration and understand this patient and what would this patient want, because the road to recovery sometimes is very short, and you do great. You just do wonderful. You just get treated. You have all of this thrown at you, the kitchen sink, and you walk out of the hospital, and everybody is just amazed and so happy for you and your family. I think everybody deserves a shot. But you really have to look at what this patient's overall health condition is and what their recovery is before you embark on a protracted ECMO course, because even if you get that patient weaned, what is going to be their health-related quality of life after this is all said and done? And that burden usually falls on the families to have to make that decision, and it's very difficult for them to do. And just because the score says this doesn't mean that you actually take that. You have to take all of this with some level of skepticism and say, I know the score says they're a +1, but I'm looking at this patient, that's not +1, or it's -7, but that's not a -7. They look better than that. The individual, the decision to accelerate care to what is now known as the highest you can get, short of transplant and permanent VAD or durable VAD, mechanical total artificial heart. ECMO is just short of that. It is just literally underneath it. And we have become very technologically advanced and really good at what we do. And we can do a lot with machines, but we have to really take into consideration whether or not we should be doing it in this case or not. That's the end of my slideshow. We could, if you'd like, open the phone lines again. I think they're open. Do we have any questions on the YouTube or LinkedIn or any of that kind of stuff that I can answer? And if not, I can spin the wheel. Where's Magic? Oh, he's looking for a nurse again. Okay. Well, let's spin the wheel, and if there's a good question, or somebody wants to call in, you'll win whatever I call it. I want to go over that again. That was really important. A couple of things I want to talk about again before I forget. And that is Alan Klima. I don't know Alan. I talked to him on the phone one time. Donated all this stuff, okay? It was so incredibly kind of him. It's ALW Klima. And can you do me a favor? Can you share my phone? I just want people to see this. I may as well do it this way. Joe's iMac. There. Let me put this up. I think this is really important. Okay, there it is. Okay, so if you look right here, I don't know how to make it just that, but Alan Klima. Can you highlight it with with the mouse or anything? Yeah, right there. ALWklima@gmail.com. And they are some really, thanks, man. And they are some really cool things. There's the hat, there's the surgical caps, they're different colors, camo, red, green, blue, black, T-shirts, which I showed you earlier. I think these are great. Somebody wants to call in, they could win. And let's see what they're going to win if they do. If not, I'm going to win it. You know what? I'm going to win it myself. But if we had Magic here, because he's out looking for a nurse, he could tell me if there's any good questions, because I simply don't know. I don't have any access to anything up here today. Spin. Do we have sound? We don't have sound. There you go. I'm going to do it again now. Doesn't count. I don't care. T-shirt, I don't care. I'm spinning it again. Spinning it again. Okay, this is for real now. The Tammy Sparacino Journal Club Casino wheel. And somebody is going to win one of these fabulous perf web cups coming your way. Okay, cool. Let's see. It's kind of bright. Can you see it? Yeah, perf web, nice red inside, white on the outside, red handle. These are really pretty cool cups. Okay. I don't know what else to say other than if I knew we had somebody who was had a question or anything, it would help. Do you want to look over there and see? Yeah. Okay, well, it is what it is. Not going to worry about it. If somebody has a question, they can email me. You can email me. You can remember John Ingram does his knowledge nuggets. I think let me go over. Let me look at what our next program is, because our next program is definitely going to be good. We finally got people. I told you we got people hired, and they're catching on really fast because we only hire the best because we're the best group. There's no question about it. If you want to work in Houston and you want to be a place where you can really practice your trade and work with absolutely the finest people I've ever worked with, and I've been doing this a very long time, give us a call. We're still looking for one person. More on the south side of Houston, but we are still looking for one person. So if you have an interest, just please reach out to us. You can either contact me at, I think it's, go to our website, het.us, and if you go right there, thanks, man. If you go to that website, you can actually email me directly through that website, or you can contact me at info@MediWeb or contact at Perfusion Education, whatever you want, and let me know, because we are definitely hiring. And I got to tell you this story. I don't know if you have time for just a story, just for a second. Yesterday, I was walking through the lobby of a hospital. I think I can say what hospital it was. No, I better not. Maybe I shouldn't. So, no, I won't. So, but I was walking through the lobby of a hospital, and I heard somebody call my name. And I looked, and I didn't recognize this person. But they came up to me, and they're a perfusionist, a colleague, okay, from Plano, Texas, which is about 4.5 hours north of where we're located now. And they knew me. They recognized me, and I was wearing a mask, but they heard my voice. They recognized me from these programs. I couldn't believe it. And anyway, her sister was in the hospital, having surgery, nothing related to do with the heart. And so, we talked for the longest time, and she told me that she had an incredible experience there at that hospital, which I was very happy with, and it is an excellent hospital, I will tell you that. We have several of them here in the area, which are just outstanding and exceptional. But that one in particular hospital, they really seem to be hitting Grand Slam home runs almost every week. And with that said, she recognized me from these programs. I thought that was so incredible. So, my childhood dream of being a movie star is coming true. I'm now a YouTube star, apparently. So I was so incredibly happy with that, and glad that people are watching, and that the programs are well valued and appreciated. And hopefully, we all learn something. I know I learn a lot by doing this. I learn probably more than anybody else does listening to me, to be frank with you. But anyway, Thursday, June 17th. I'm sorry. Is that right? June 17th? Is that right? Oh, that's today. Oh, okay. So Wednesday, July 7th, we're going to be coming to you live from Vanderbilt. Now, Vanderbilt has a studio. It's the MediWeb studio at Vanderbilt, and we do every month. It's the first Monday, predictably, of every month, from 6:45 until 8 o'clock, the Vanderbilt University Medical Center Department of CV Surgery Faculty Forum. It's going to be on understanding alpha stat and pH stat, because I'm really interested. I need to really pay attention and learn this, because I know it exists, but I don't completely understand it. I've always had a hard time with that. But actually, Tammy Sparacino and I are going, I believe, if things go well, fly to Nashville along with Min Tran. He's going to join us, and we're going to do the journal club from there. So we're going to do everything live from Vanderbilt along with those guys. I'm really looking forward to it. But I have to compliment Matt Warhoover, Tony Lepore, and he goes by Joey, right? His name is Anthony, but he goes by Joey. Joey Lepore and Dr. Jordan Hoffman. Those guys have been so incredibly supportive of this program, and their Vanderbilt forums have been very well received with great viewership. So I'm very happy about that. But we're going to come live from Vanderbilt. So we're going to do that. Tammy is going to do her journal club on the commentary, taking the next step in cardiopulmonary bypass management. I think that's going to be very instructive, very interesting. And then John Ingram is going to be talking about his knowledge nuggets and how does protamine really neutralize heparin. I think that's going to be very exciting. And it was very interesting because we had a call, a concern here in Houston. I don't know if anybody else had this issue, but we had a shortage of protamine. So we were having to do our cases with Angiomax until that protamine shortage, and it was a national shortage, so I'm assuming other people had that problem. Some hospitals, for some reason, had a higher supply, so we really never had that issue, but a couple of hospitals had to convert to Angiomax because their supplier wasn't able to get it because there was this national shortage. Hey, Magic, do we have any questions or comments on the web? No questions? Okay. So I'm winning my own cup, and I'm winning my own surgical cap because I have one now that's blue, but I'd like a black one. And with that said, I'm going to bid everyone adieu a little early, but we'll make up for it next week. The program today was approved for 2.4 Category 1 CEU by the ABCP, and the program next week is going to be 3.4 Category 1 CEU. On July 7th, forgive me, on Wednesday, July 7th. And, just so you realize, and I think I've said this before, all of our programs are free. You can watch this program, you can learn from this program, you can participate in this program. You can join perfusioneducation.com. All of that is free. But you only pay if you need the CEU certificate, which you can do through perfusioneducation.com. It's very affordable. I think it's roughly $15 a CEU. So in terms of affordability, it's there, and we constantly are adding more content. So you have more than enough content to get all your CEUs. Now, with that said, I don't think this, even though I think this online format is fantastic, I think that it brings real value. I think it was serendipity that we were up and running during COVID and that we were able to provide this. I think that just, again, by happenstance, we just happened to be in the right place at the right time to start this program. We want this program to continue to evolve, but it can't replace live programs. I will tell everyone that I think that whether it be in New Orleans or whether it be in Houston or whether it be in Nashville or whether it be in New York or whether it be in San Diego, wherever it is, Vancouver, Chicago, pick the place. I think that live programs add a value that you can't get in this online world, and that is the face-to-face collaboration and networking that you can get. So I think that we have to constantly evolve too. We are looking at moving our studio to another location, which is going to add. We can't do everything we want to do here in this studio, though I think this studio has really done the people, of course, it's the people, but technology and the people. But there's only so much they can do with the space that we have. And in order to continue to make this experience something that you want to be a part of, want to be interesting for you, and also be, to some degree entertaining, we need to continue to advance technologically. So we are looking at a new studio, which is going to have some real advancements to it. We are trying to hire a nurse, so if you are a nurse and you're watching this and you have an interest in education, please reach out to us at info@mediweb.us would be the best way to do that. you're a perfusionist looking for a job, you can look at, especially down in the south of Houston, is where we're looking. You can reach out to us at het.us. And by all means, please go to the App Store or on Apple, or go to the Google Play Store on your Android device and look at the MediWeb app. It is a fantastic tool that I use every day on my cases, and I use it while I'm watching ECMO, and I've shown it to nurses, both the big app and the little app, which is the IV drug dosage calculator, and they have really seen the value in it and enjoyed it. And it's, like I said, it's 99 cents for the small app. It's $2.99 for the larger app, which has the small app in it already. And I think it's a fantastic tool, and I would appreciate very much you looking at it, buying it. Please leave an evaluation of it. What's that called, Magic? A rating. Yeah, please rate it. It would be very helpful to us if you would do that, and share it with your friends and colleagues so that they can have it too. So with that said, I'm going to bid you adieu. I want to thank you again for your time, allowing me to give you these 2 lectures today. And I'll look forward to seeing you when I'm in Nashville on Wednesday, July 7th at 6:45 a.m. Take care. Thank you.